time of the day. Okay, so today we continue the topic discussing how the partial removable dentures with acrylic denture base are made. We finished previous time discussing clinical procedure of occlusal registration, which is necessary for the placement of the models together in articulator, and mentioned the question of selection of artificial teeth, which is also somewhat a responsibility of a dentist, as normally the dental technician does not see the patient, they don't meet, so there is no idea how should the artificial teeth match the existing remaining natural ones. So the dentist is to take a shade guide and select the shade of the teeth. Speaking of the shape, in partial denture, dental technician is supposed to watch the size and shape of the remaining natural ones, which is seen on the model. But definitely sometimes dentist gives some special recommendations for this. Anyhow, the models come to the dental lab. The dental technician adjusts and mounts two models with the help of occlusal registrators and mounts them to articulator. I think you remember articulator is the apparatus machine which reproduces the movements of the lower jaw done with occlusal muscles. So we have different articulators. Sometimes they are quite primitive ones. In Russian language, articulator was used mostly for the machine which makes reproduction of the moves to all directions, and we had specific word occludator, meaning that it was only vertical movements. That's what you see a lot in our clinics when we do partial removable dentures with acrylic denture base. Anyhow, after the models are set, the first work of a dental technician is to make the clasps. Clasps are made from wire of stainless steel, 0.6 to 1.2 millimeters diameter, and additionally one can take a gold wire, but as you remember, we need a special license to work with gold in this country, so gold was rare only for some special cases, like for example allergy to the components of the alloy of the stainless steel. So the wrought wire clasp is bent with a special pliers. These pliers in Russian are called крампонные щипцы. Crampon is the name of a pin which exists in the artificial porcelain tooth. So this clasp consists of three parts. First, the shoulder or arm is bent, and this is the part which is always on the vestibular surface, on the neck of the tooth, means below the equator, below the clinical equator, and approaching the gum. It's not coming on the gum, so because that we don't want the clasp to jam the gum, the gingival tissues, when the denture sits deeper and when the patient is chewing on the artificial teeth. But this is how the shoulder or arm goes. We have various translations from Russian. That's why we use both in this case, shoulder or arm. And this comes to the proximal surface below equator. And then the second part, the body, starts. The body is on a proximal surface, and it is done in two sharp curves. First, it goes up above the equator, and then the first sharp curve is done and it goes down, and at the level of the gum, second sharp curve is made. This makes the clasp have some elasticity, and this allows us to sit the denture over the proximal surface, which also has some equator. When two teeth are standing together, the equator on proximal surfaces makes contact points in the dental arch, in tooth row. When one tooth is lost and we have the abutment tooth standing near the defect, we still have this equator, so we need to pass it. We need to have some elasticity, thus this part as body is bent. And third part is called sometimes ramus, sometimes process. Anyhow, it is in the denture base, in acrylics, and the dental technician, after bending all the parts with pliers, take a hammer and makes this ramus or process flat. This prevents rotation of the clasp in acrylics of the denture base. This is positioned exactly to the midline of alveolar ridge. That's under the artificial teeth. This is the correct position of it. If it's not in the proper position, then usually we have the problems in seating the denture to its place, to the prosthetic bed. After this, the dental technician is to choose the proper set of artificial teeth and to make the arrangement of artificial dentition. So the tooth form is selected according to the size and shape of the existing teeth in partial denture. And sometimes the dental technician needs some special adjustment, like you see on this picture below. So now this tooth looks like existing natural one, and this makes dentition looks nicer. Okay. And after the set of artificial teeth according to occlusion, now this is called a trial denture or waxed up denture, and this construction with the articulator is sent to the dental clinic for the next clinical stage, which is called verification of denture design or trial fit of waxed up denture. So we have the clasps and the artificial teeth, which are the ones that will stay in the made denture, but the denture base is still from wax. It has the wire in it to reinforce it, and possibly the margins are not that exact. And the thickness of the denture base plate done from wax is a bit different in different places. That's possible. It happens in making of this arrangement of artificial dentition. So why do we need this stage? Because it turned out in normal life that we can make mistakes, as well as dental technician can make mistakes. And sometimes these mistakes, like of arrangement of artificial dentition, are not seen in the articulator, and we can see them only in the mouth, because they turn out only in proper position of the head of our patient. At the same time, there is a chance of a dentist to make mistakes in doing the occlusal registration or taking impressions. And this is also possible to check, to find in the verification of denture design in trial fit. So if we find this mistake, we send the articulator back to the dental lab, and the dental technician is doing the correction of these mistakes without any hesitation and usually free of charge. And if these mistakes were neglected, if we skipped to do this check in the mouth and we found this mistake in the ready denture, then we are in quite a big trouble, because the ready denture could not be corrected to a big extent, and thus we are to remake it completely starting from the very beginning. The patient is not happy to come 3 or 4 more times additionally. The dentist is not happy to do this work free of charge, and the dentist is definitely not happy to pay for the dental lab for the remaking of the denture, because this is completely the fault of the dentist. So we are to do this stage. It consists of 2 parts as usually. First, we need to check the denture on the model in articulator. And second part, if we like everything that we see on the model, we take it off the model, disinfect it, and check in the oral cavity. So what do we check on the model? First, we need to check the base plate. The margins were marked with a pencil on the model, and we need to check them again. Then we check the thickness of the base plate. We have a micrometer for wax, or we can look it with this base plate, look through to the sunlight in our window, and if the thickness is different, we'll see that it is so. Definitely we need to see no balance of the base plate on the model. We should see that all parts and all pieces of base plate are on the model without any gap between them to the model. Second, what we check is the retentive elements, usually that's clasps. They are new for us. We did not see them in occlusal registration, so we need to check that the dental technician did all this correctly, that the wire is bent correctly, that the wire is proper size in diameter, and so on. And that the clasps are on proper teeth in proper position. Then we check artificial teeth. We check the arrangement of dental arch, tooth row. We check occlusion, whether it corresponds to what we need for this patient, and we check the shade and shape of artificial teeth. Okay, we have 2 more small details to check. However, quite lots of time, many students forget this. So let me remind you that we need to check that the models are fixed properly, mounted properly in articulator, because if the midline of the model does not correspond to the midline of articulator, or the occlusal plane of the model is not parallel to the plane of our table of the floor, we are likely to see that artificial teeth are not standing straight or how they should, but they are tilted altogether to one or other side. And after we checked this, we take the waxed up denture off the model, and we need to check that the model is still in good condition, because when doing the arrangement of artificial dentition, the dental technician is softening the wax with a quite sharp spatula, lab spatula. So if the dental technician cuts through all the wax and scratches the surface of the model, then the denture made on such a model is likely to damage the mucous membrane when the patient is chewing. So if we see this, definitely we'll have to retake the impression and make a new model that the denture is made on. And hopefully it fits to this model of the waxed up denture, so we don't need to do anything else. So if we have any notes that we do not agree to at this stage, we are to return the waxed up denture back to the lab for the correction. Or definitely the dentist having hands can do some minor corrections himself or herself. And so if we like everything that we see in the articulator, the second stage is verification in the mouth, in the oral cavity of the patient. So we take the waxed up denture off the model. In the 21st century, definitely we need to disinfect this construction before inserting it in the oral cavity, possibly washing off the disinfectant if it's irritant, and sit the denture in place. And in the ideal variant, the situation duplicates the models in articulator, meaning that we check the margins, the fit of the denture base. Then we need to check that artificial teeth are in proper position and the clasps are in proper position on the abutment teeth. And after this, we ask the patient to bite together and we look at the occlusion. And if we like everything, then we give a mirror to the patient and ask the opinion of the patient about this. If the patient agrees to the arrangement of artificial teeth and some other specific features of this denture, then we take the denture out of the oral cavity, sit it back on the model in articulator, and send it back to the dental lab to finish, to let the dental technician finish the denture. So, processing the trial denture is a laboratory stage which happens after the verification of the denture fit design. So, as you see what's written here, possibly if the patient wanted to have something be corrected, or the dentist noticed some errors which were sent to be corrected, even sometimes if the occlusion is wrong. For example, we did registered front occlusion instead of centric one, then we'll need to send do a new occlusal registration and send the denture back to the lab to have the dental technician perform the new set of artificial teeth. Okay, possibly that's not necessary if we did everything correctly. Anyhow, some minor corrections are still possible. And when we got the approval of the patient to finish the work, then this laboratory stage includes waxing up of trial denture, wax carving done for teeth and root, and soap polishing. Then the processing of acrylic resin includes such stages as flasking, dewaxing, packing, curing, finishing and polishing procedures. And after this, the ready denture is sent to the clinic and there it's inserted, or sometimes we say fit and sit, and then followed up till the final result is achieved, till the patient is coming to the dentist happy with the denture. So, the final, before we start about flasking, let me remind you that final work with wax is done by dental technician and is necessary to make the waxed up denture look like the future acrylic one. So, as the denture base has the wire to reinforce it, and we don't need this wire in the ready denture, the dental technician is removing it. Usually, the dental technician is removing not just the wire, but cutting out all the palatal part in upper denture or lingual part in lower denture, and then softens a new plate of a base wax and adapts it to the prosthetic bed and glues with the existing wax under the artificial teeth with melted wax. Then, after this, the margins are checked, and sometimes if the margins are a bit short, the final size of a margin is achieved with a portion of melted wax which is poured to this margin and then corrected in width. After this, the waxed up denture could not be taken off the model as the wax glues it to the model. This is not necessary anymore, just the idea is that we send the denture to the lab and we cannot get it back in waxed up variant, but only in the ready variant done completely from acrylic. Okay, and sometimes we also do some additional carving of wax to make the acrylic denture base look more like natural teeth and alveolar ridge, as usually in arrangement of artificial dentition, the dental technician just inserts the artificial teeth in wax. But then, if the patient is an elderly one, the dental technician is making the artificial dentition look more like natural one, meaning that removing the portion of wax off the necks of teeth, we can make it look like a recession of the gum. Then we ask the dental technician to model juga alveolaria. These are eminences on the vestibular part of alveolar ridge, especially in front. The biggest is in canine. You studied this in anatomy. You feel that alveolar ridge is not exactly smooth. We have eminences on it where the roots of the teeth are located under, especially in canine. The dental technician is not doing this in back teeth because the smooth acrylics is easier to be cleaned, but in front it's better to do this. And in upper jaw sometimes the palatal rugae are also modeled. So, doing all this, the dental technician makes the surface of the wax base plate smooth just from heating it a little bit, and that lets this to cool down, so partially melted wax becomes more smooth. Sometimes this is also polished additionally with just some soap and water. So, and after this, the dental technician removes the model with the denture from articulator and starts the flasking procedure. Flasking is the first procedure which is dedicated to replacement of acrylic denture base with wax denture base with acrylic one. So flasking is the process of investing the cast and the wax denture in a flask to make a sectional mold used to form the acrylic resin denture base. So mold in this case is like an impression where the acrylic will be put and make a shape of the denture base. So the flask that the dental technician has consists of several parts. This is lower half, upper half and lid. Lower half is one piece, upper half has a lid which is attached on it additionally. So, in order to put the model in the flask, the dental technician is doing a number of procedures. Let me remind you that according to the way how the model is put in the flask, we have the direct or straight flasking, we have inverted flasking, and we have combination flasking. And usually nowadays with the technique used for acrylics, when we have the dentures which have the base with vestibular flanges, the dentures which have acrylics covering the alveolar ridge on the vestibular side, we use the procedure which is called inverted flasking, which means that the model is coming, so to say, upside down compared to what we saw in direct flasking or straight flasking. And this was done for the rubber denture bases which were used before the acrylics was invented. Anyhow, to let the mold be separated from the flask after all and everything is done, the dental technician puts some Vaseline on the walls of the flask and pours plaster in the flask and inserts the model. The model is dipped in the plaster layer up to the margin of the denture base. Definitely no plaster should be put on tooth and wax at this moment. So after the plaster sets, dental technician puts one more layer of Vaseline over tooth and wax and the existing plaster which is made smooth to make separation of two pieces of plaster possible. So after this Vaseline application, dental technician puts upper part of the flask over, fills upper part with plaster till the top, and then covers the upper part with lid, and the lid pushes the excess of plaster out. And then the dental technician waits till the plaster sets completely. This is the picture to show the procedure. Plaster poured, model dipped to the margin of the wax. Then the upper part is put over. Okay, this is how it looks like when just the first portion of plaster was put and the model with the waxed up denture dipped in. We see that wax is not covered with the plaster and the tooth is not covered. Definitely if we have a bigger denture, like regular acrylic based denture, all the teeth are not covered with plaster. So after the set of second portion of gypsum, we are seeing the procedure done wax elimination or dewaxing. This flask with waxed up denture is put in boiling water. The wax melts. After this, the flask is opened and all the artificial teeth goes with the second portion of plaster to the other part of the flask, to the upper part, to the lid. Here we see just the model showing the alveolar ridge. If we're doing a partial removable denture, then the artificial teeth still present, go to the upper part, and the existing natural ones shown in the model are also going to this other part, and to have them go like this, dental technician cuts them from vestibular surface before starting the process. So the wax is washed out with this boiling water, and now we have a gap in the flask between the artificial teeth and the model for the thickness of the acrylic denture base. But not to let the acrylics connect to the plaster, not to let it stuck with the plaster, attached to the plaster, we need to put substance which does not allow it to stick in the place where we don't need it. This is called separating media. Sorry for misspell in this slide. So separating media is a substance which prevents sticking of the acrylics, pink acrylics of the denture base materials to plaster. The ones used are different ones. Sometimes that's tin foil or starch solution of Vaseline or cellulose acetate, but mostly this is a 1% solution of alginic acid. It makes a film, and now the acrylics won't stick. After this separating media dries, the dental technician is preparing the acrylic resin. Acrylic resin coming commercially is a heat cure acrylics, as we discussed in previous semester. Just it is pink to look like a denture base, like mucosa, not like teeth. So it's also powder and liquid, mixed 3:1 ratio by weight or 2:1 ratio by volume. The dental technician takes the necessary amount of acrylics. Usually this is 1 gram of powder and the corresponding amount of liquid per each tooth in the denture. After mixing, the acrylics goes through usual regular curing stages. Sand stage, looks like wet sand, then threads or stringes. When we touch it with spatula, we see the stringes or threads which pull to the spatula. Then dough. Do you remember that that's the English name to what bread is made from? Okay, so this is the working stage. The acrylics is elastic. It can be molded, but at the same time it does not pull to our instruments and hands. It's not too sticky. Then rubber. It is elastic, but if we push it, it returns to original shape, so we cannot work with it anymore. And hard or stiff or solid, this is the final stage. So, when the acrylic resin reached the dough stage, we need to press it into the mold. Usually it's sculptured to the proximal shape of the denture base and put in the upper half of the flask. It's put on the model. Okay, and then two pieces making the flask are united together, and the teeth are pressed in the acrylics. To make the teeth attached to the denture base acrylics, we need to use some additional work, as we use the monomer, the liquid of acrylic resin, to cover the lower part of artificial teeth, and it works like bonding agent. So first, the two pieces of the flask are united not completely, but a small gap is left between them, and this lets the dental technician the possibility to open the flask and to check whether the acrylic came to all the necessary pieces where the denture base should be. After this, the excess is removed. Two parts of the flask are pressed nicely together till the complete connection, and the flask, now as a one piece, is secured in a special clasp to hold two pieces to each other tightly, and the acrylics is cured. The cure of acrylics is usually done by heat. We use the heat cure acrylics to make the dentures. Self-cure acrylics possess the properties which does not allow us to use it to make the dentures which are used for many years. Microwave curing is done with some special acrylics that usually we don't see in the dental lab. So, just as the acrylic set is the reaction which comes with release of heat, first we put the flask to the normal tap water, and it's heat for 45 minutes quite slowly till it reaches the 80 degrees. Then we bring the water to boiling faster. Then we have it boiling also about 45 minutes for many kinds of acrylics, although one should look in the instruction for this new material that the lab buys. And then we allow the flask to cool slowly in the same water as it was prepared, cured. Then deflasking means that the flask is open by the dental technician, the plaster is broken to small pieces, and the denture is removed. To do this, first quite big, unpleasantly looking instruments are used, like hammer, special pliers, gypsum knife, and then we use smaller machines like grinding lathe. This is the engine of a dental technician. Okay, then we have different instruments to use with this, like acrylic burrs are big burrs used to cut big excess of acrylics. Sometimes we have special dental stones used for this purpose. And it goes through the procedure that first big excess is removed, then smaller access are cleaned with some rotary instruments and some other instruments, even like spatulas and knives. Then the surface of acrylics is made more smooth, usually using sandpaper. And then it's polished with different brushes. We usually have special polishing lathe, which is quite big machine in the dental lab. Pumice is an abrasive material used to make the surface smooth. Then brushes and drag wheels are used for polishing of acrylics. Or sometimes muslin buff wheel is also the instruments used for the procedure. You need to know these names. So the ready-made denture is cleaned, washed and sent to the clinics. The patient comes, sits in the chair, and the dentist is to place the denture in the mouth on the prosthetic bed. So this also takes time. It's usually it's much longer than the trial fit of the waxed up denture, as many things that the denture base made from wax allowed us to sit the denture on the prosthetic bed are now not possible because the acrylic is much harder. So we need to sit the denture exactly to its place, and we need to check this. So this is called adjustments to bearing surfaces of denture bases. After this, we'll need to adjust the occlusion in harmony with natural and artificial dentitions. And then the third part of the procedure are instructions to the patient. To check the fit of the denture, the dentist uses special impression paste. It's put on the lower inner side of the denture base. The denture is set in place, and if we see that some place is where the paste is pushed all the way through to the gum, then we know that this is a high spot and we need to correct it with a stainless steel bar or carbide stone to remove it. Then the denture sits deeper. In case of acrylics, if we see big discrepancies with the denture base, that the denture does not sit completely, usually we can use easier instrument. We use just articulation paper that we put between the abutment teeth and the denture base and try to sit the denture and balance it. And the places of a high spot are marked with some dots or lines, which are traces of the high spot, and then we cut the denture base. Usually we don't use articulation sprays that we use to sit the framework, metal framework of a PFM bridge on teeth. There are some rules. Usually the idea is that if we have some margins coming in the undercuts, we cannot sit the denture because this causes pain. But if we relieve it from inside, then we'll have a trap for food. So we prefer to shorten it in a way that it still touches the alveolar ridge, and possibly it is shorter, but then it's not jamming the mucous membrane and the denture sits deeper. Okay, so we sit the denture, then we harmonize occlusion with articulation paper and same instruments. We need to polish all we cut, all surfaces that we cut, to make them smooth enough. And then we need to talk to the patient to explain all the difficulties of possessing the denture in the first time and adaptation to the denture. Speaking of adaptation, we use the theory of Professor Kurlansky. He described 3 phases of adaptation. First phase is called irritation phase, second is phase of partial inhibition, and third phase is phase of complete inhibition and damping. Sorry. So in the first phase, irritation phase, we see that the denture is not making the patient happy. So it's at the first day, in the day of insertion. So it's felt exactly like foreign body. And this means that manifestations of irritation are increased salivation and possibly a gag reflex. Then the patient has the lips and cheeks which are trying to push the denture of the prosthetic bed. So the patient feels discomfort because the lips and cheeks were used to be positioned more inside, and now we have the denture margins which push them outside. In this day, usually the patient is not able to chew nicely because the mucous membrane is not adapted to the pressure coming from occlusion yet. And in the upper denture more, less in lower one, but as the places where the tongue touches to make some sounds are different, then we have sharp change in diction. The patient lisps. But if the patient is not afraid of this and continues to use the denture, all these bad features fade subsequently. So, in this phase of partial inhibition or damping, which is seen from 2nd to the 5th day after insertion of the denture, the bad feel about the denture goes away subsequently, and the patient starts to feel the denture naturally. Anyhow, the adaptation to this kind of a denture takes longer, significantly longer than the one to the fixed denture. Anyhow, if everything goes correctly, then we see the phase of complete inhibition or damping coming. This means that the patient does not feel the denture as a foreign body anymore, and possibly even feels discomfort when the denture is outside of the oral cavity. The muscles and soft tissues are fully adapted to the new relationships of dentition and occlusion, and the functional capacity of masticatory system is at its maximum. So the denture serves for chewing now and performs all the other functions that the denture is replacing. However, these 33 days as an average was the opinion of Professor Kurlansky. Newer studies show that even when the patient is adapted to the denture, it takes longer for the muscles which move the jaw to get adapted. So, in some studies, even one of the studies done in our university, it was shown that muscle adaptation can take up to half a year. Thus, we need to be sure to make the patient know that some discomfort is normal for quite a long time. However, if all the other feels about the denture are not that bad, the patient should not reject the denture. So, what should we say about instructions to the patient? First part of our work is to teach the patient to put the denture on and take it off, independently of us. Usually, we check this coming with the patient to a mirror. Thus, you see a big mirror on the walls of most of our clinical rooms. So we go to the mirror with the patient because the patient needs to wash hands usually. Then the patient needs to remove the denture with both hands. This is the proper way. Most of the dentures are removed nicely only with both hands. So we show to the patient how to do this, and then let the patient practice and check that the patient is doing this independently. Definitely, it takes longer to get used to this, but we let the patient go home, being sure that with some difficulty the patient can take the denture off and put it on independently from us. And if the patient practices this at home, next day the patient will surprise us doing this much faster than us. Okay, have a look that we instruct the patient how we usually teach to remove the clasps from abutment teeth. Then we need to talk about this discomfort, feel of foreign body, and so on. Usually that feel goes away easier if the patient has some candies that he can suck on, like mint candies of some kind or something else. This helps to fight with gag reflex and prevents excessive salivation. Then we should say that even with our adjustment of the denture surfaces, the patient is likely to get some trauma under the denture base, and this is not that difficult and bad, but the patient should contact the dental clinic next day for the regular checkup. If the pain is big, then the patient is to take the denture off for night, but the denture should be put on 2 to 3 hours before coming to our clinic, and the patient should come with the denture sitting in the mouth. This is necessary because some people try to tolerate it as long as they could, but after they remove it, the signs of trauma fade very soon, so there is a painful mucosa without any signs showing us how we can correct the denture. Okay, I think if we have enough time in the last part of our lecture course, you will get some additional information on this from me. Okay, so phonetics is usually restored in the first day if the patient is practicing to talk. So we suggest for the patient to talk as much as it is possible, and if the patient is shy because of this change of diction, because of lisp, then we suggest that the patient is reading a book, is talking to TV, is telling someone poems, and so on. The more sounds are said, the faster is the recovery of speech. Okay. Then we need to instruct the patient about the oral hygiene. The denture is cleaned, taken out of the oral cavity. Normally, the patient with partial edentia is using the same toothbrush as is used for the remaining natural teeth, but the denture is cleaned, taken out of the oral cavity with the same toothbrush and possibly toothpaste. If patient wants to save, we can recommend a special harder toothbrush and possibly a cheaper toothpaste because it is not that important for the cleaning, but the brush should go over all the inner surfaces as well as outer ones. In the daytime, after taking a meal like a dinner, if the toothbrush is not at hand, the patient could still take the denture off if there is a sink with running water, wash the denture from the food particles, and rinse the mouth from it. We should say that some food trapping under the denture is normal. It happens in the same way to the natural teeth, but here, just because of the feel of the new denture, it felt more unpleasant. At the same time, cleaning of this denture is much easier than cleaning of the natural teeth. So even the person who is looking for the handicapped person can help this person to clean the removable denture. Okay. We have some additional source of cleaning, is like cleansing tablets that make a solution to soak the dentures for 15 minutes once daily or longer. These are usually coming in the shape of tablets. Okay. You can read all this text on your own if you pause the lecture. That's why I don't stop on this for a long time. Okay, so speaking of using the denture at night, it depends. Nowadays we come to the point that if after adaptation using the denture at night is more comfortable to the patient, they better use it. But for some patients, the denture, even after adaptation period, is also felt something like a shoe that we wear all the day, but we want to take off for night. And this depends on the type of a nervous system, sympathetic or parasympathetic. Thus, those who want to leave it to put it on after cleaning before sleep are allowed to do this. We suggest to the patients to wear the denture for the first week after insertion, definitely after the thorough cleaning before sleep at night, just to let the adaptation period go faster. Then, after getting adapted, the patient makes this selection how to use the denture on his own. Okay. There are some conditions that we insist on wearing the denture at night, especially when we are afraid of the condition of teeth, periodontally weak teeth or increased load like bruxism. Okay, definitely at an interval of 24 hours the patient is supposed to come for control appointment. Okay, then we have procedures which are coming to the denture not normally, but in case that something happens in some time. And this is usually relining and rebasing. So you see, relining is making the surface of the denture adequate to the alveolar ridge if in some time the recession of alveolar ridge went on and the denture is still suitable for the patient from other points of view. And rebasing is quite rare. This is if the denture base was made wrong and the artificial dentition is still in suitable condition and we want to save it. Thus, we change the entire denture base with new material completely. Okay, if we have enough time at the end of semester, I would like to show you the fine details of this. Otherwise, let me remind you that exactly this lecture is also present in a Word document file as a text on the website, on the page of our chair at e-learning. So you can read it on your own if you need. Okay, and these are the kinds of repair which happens normally or usually to the denture. Acrylic dentures are quite easily repaired. We can repair almost everything. We can replace broken or lost prosthetic tooth, or if some natural tooth is extracted, we can attach an artificial tooth to the denture base instead of removed one. We can repair broken resin base, and even if a clasp is broken, we can bend a new wire clasp, rod wire clasp, and then attach it in the denture base with some self-cure acrylics. Most kinds of repairs are done with the help of a self-cure acrylics. In case of a metal framework of a denture, many repairs are done with more difficulty, and some are not possible. Still, the partial removable denture is repaired much easily and does not need replacement in case of many problems coming to the dentition of the patient after insertion of the denture. However, it's still necessary to underline to the patient that removable denture should serve for 3 to 5 years and no longer, for the many reasons that happen in the normal dentition and alveolar ridges. That's all that we wanted to say you about acrylic-based removable dentures. So, thank you and goodbye.